Hey all, this is your second installment of Thursday Video Time. A couple things that I want to share with you today are related to population health and how we actually understand risk. So one of the first things I want you to start thinking about is our discussion about public health models that we had on Tuesday in class. If you weren't present, missed part of that discussion, or just want to recap, make sure to go back to week 1 materials. And in the week 1 materials, there is a link to the slides in that page. And on the slides, it is, I believe, slides 2, 3, and 6. Spend more time talking about the models and how we would actually use those in public health thinking. So we went through a couple of examples in class just to get you thinking about how the models are used to disseminate information, and then also simultaneously how those are our models internally of how we receive public health communication. So this week, you're going to be considering population health and how we actually start to quantify risk. So in this week's videos and materials, you have a couple sets of slides on population health and another one on epidemiology. Please do take a look at those so you can get a sense of where did this actually come from. In the population health slides, you'll see a little discussion about the history. How did we even start breaking down public health into populations or communities of risk or communities that have experienced inequities or disparities? What did we actually start to use as to create categories? So some of that was race, some of it was ethnicity, some of it's geography, some of it's language. But also consider that what happened in population health as specific and distinct from public health is that we saw outcomes. So there were things happening out in the healthcare world, like high blood pressure then relating to a stroke, or cardiovascular disease relating to a heart attack, or environmental disasters, oil spills, asbestos, nuclear plants blowing up that related to cancer risk. So we started to correlate these outcomes with the presence of health conditions or health behaviors. And that's how population health came to be. So then we started categorizing people based on health conditions or health behaviors. So people who smoke. So that's a form of population health. Then became part of public health, in that in order to make our larger public health sphere, our larger community healthier, we broke it down into these populations. So a different way to think about this is that public health is sort of like the larger umbrella of like health for all. And what we did in creating something like population health is that we started to look a little bit more closely, like, okay, where are we seeing our biggest drains potentially, or negative effects or influences upon health for all? But I want to backtrack a little bit and say that also requires some agreement. So this is part of your discussion. Can we agree on what makes us sick? It requires some kind of agreement on what's a negative outcome, what's a negative influence. Is having a community, a subset of our community engaged in a health behavior that is causing them to be at higher risk for stroke and heart attack, say like smoking, a public health issue? Now, we're all raised to some, and acculturated in a way that, that feels, of course, that's true. Partly because smoking also doesn't just affect the person who's doing it, it affects the people around them. That's one piece of public health, determining whether something in public health is actually a public health issue. Does it affect other people, or does it just affect the individuals? But what also we started to look at from like health for all isn't necessarily just about the outcomes. It's also about how it affects the healthcare system that we all pay into with taxes, because our tax money support Medicaid programs and Medicare nationally. But also our tax dollars subsidize defaulted bank, healthcare costs and things like that. They also somewhat subsidize people who have to declare bankruptcy because of healthcare costs, which actually is one of the most common causes of bankruptcy. prior to the ACA and the healthcare reform in 2010. So you could make an argument that really anything that affects anybody's, even individual health, is a public health concern because on some level we all pay for it. So that's one of the possible agreements we can make. But in order to decide that a population's behavior was a public health risk, we had to decide that that negative outcome or that negative influence was indeed negative, and that it was affecting everybody's ability to obtain health. But I want us to think about the fact that one of the questions we didn't get to answer in class the other day is who gets to determine that? Who's in power? So there's some of those things in these slides as well for you to think about, is like, where is the locus of power? Who gets to decide that something is a public health issue? Well, people who are responsible for how we spend our healthcare dollars from taxpayers kind of gets to decide what's a public health issue, right? If we're all paying into very expensive care that could be prevented in some other way, either with education or other initiatives or immunizations or whatever it is, then that could potentially make it a public health issue, right? If it's something where it's like a no-brainer, where, I don't know, air pollution, and it affects every single person's lungs, you could make an argument that that's a public health issue. But in order to decide that something is a public health issue, there has to be some agreement. And so that's primarily what I want you to be thinking about in this first discussion is, can we agree on what makes us sick? Because if we don't agree on what makes us sick, then we can't also agree on what the interventions might be. And we can't also agree on what public health is. But population health ultimately arose as a subset within public health. So we notice that, say, for instance, over 100 years ago, poor hygiene was related to or correlated to increased incidence of infections in communities and spread of those infections, and maybe even creating endemic or pandemic-like situations, say like with the flu of 1918, 1919. If we can say that hygiene is related to that, great. That makes it a public health issue because you know what? If we improve everybody's hygiene, we can potentially forestall the spread of this thing and maybe even squash it altogether. Great. That would mean less sick people, less dying people, less burden on the workforce, right? Because all the people left factory work and farm work to be sick. So there's a lot of implications on, again, who decides what public health is, people who run the organizations that don't want their people out. There's a lot of reasons where we could decide that that was a public health issue. But how did it become a population health issue? It's like, oh, actually, when we look a little bit more closely, what it turns out is that very densely populated areas, like urban areas where people are living really close together, say in apartments, tenements, in very congested settings where there's a lot of waste, but no waste removal, is the cause of this issue. So what it does is it targets a certain behavior or locale or group of people to then, on some level, almost be responsible for, or now the focus of, the larger public health. That seems cool in some ways, right? It seems very deductive, let's get to the underlying cause. That's what we want to do in medicine. That's what we want to do in health. Don't throw darts at everything. Find the very, very, very key underlying thing that we can target in terms of our communication, intervention, education initiatives, and do that. And just doing that alone can change the health of the larger population, the larger public health. So addressing that one population can then improve the health of everybody. So this is how population health becomes related to public health, but in a lot of ways is still very separate because it's looking at one specific population, not everybody, and it's sort of almost making that one population, or say that one initiative, responsible on some level for the health of everybody. But then what happens in that situation with population health? People are like, well, I'm not part of that population. Why should I do that? I mean, we're seeing that real time, right? I'm not part of that group. Why should I care? So population health in a lot of ways also makes public health very complicated. So while it simultaneously could be treat the underlying cause, right? It also makes it very complicated because if you're not part of that population, well, I'm not part of, that group of people that experiences inequities and disparities and, lives in poverty because of redlining. So why do that's not for me. I don't have to do those things. And so simultaneously it can be corrective, but also divisive. Population health, however, has become the way that we do a lot of things in public health because it has this ability to be much more focused and targeted with our interventions, education, initiatives, treatments, whatever it is. That's one of the ways that, so when we look at the slides of epidemiology and science, it's one of the ways that we can track is what we're doing working, right? Because you can isolate the population and isolate the number of variables. If I'm trying to do one initiative on all people who live in Pullman and Pittsburgh and Miami and Chicago, obviously it's not going to work. We have too many different kinds of people, too many different kinds of economic statuses, too much geography, too many other factors, right? So when we focus on population health, when we look at like this economic level, this race, this medical condition, really, really isolate it. It makes it easier to then apply any intervention or something to it, some solution, right? And then see if it works. That's the epidemiology science part of this. So you guys will see in the slides. And we'll get into that a little bit more because epidemiology is much more complex than what I'm saying right now, but I want to simplify it for the purpose of this discussion. But it's also very deductive, right? And reductive about human life and existence, and making this one population responsible, but also demonized. So think about all the examples I'm sure you can come up with of how public health narratives and storytelling based in this concept of population health, really like a little subset where we narrow it down to one population, becomes very demonizing, where we start to conflate Black Americans living in poverty with strokes, heart disease, and hypertension, high blood pressure. Such that when a person walks in with black skin to a medical provider's office, oh, you're basically a walking stroke and hypertension. Think about how that plays out. Think about how that reductive, deductive way of relating to a population that might have started with like, let's improve health, right, have actually potentially become harmful as well. There's lots of examples that we can come up with this. And there's a lot of discussion and research and pedagogy, or sort of like the study of teaching and education right now happening around this very thing about how population health has actually, despite its endeavor to improve health, has actually created harm in a lot of ways for those populations, because then people start to deduce, reduce, conflate, make everything smaller with the idea that it's packageable and manageable and then we could do something with it, and also squashing people, the human beings who are part of those populations. That then when we try to pull it back up into public health, well, the reason our population isn't healthy is because these people over here are just doing things the way they're doing them, and like if they would just stop, we would all be healthy. Think about that narrative related to choosing not to vaccinate or wear masks. And like I said in class, this is not right or wrong. I'm not here to start debates on that. We will have that debate at the end of the quarter. What I am saying, though, is that it's part of that same, it's very similar conversation. That when we start to address one population as being the deficit, as kind of being the one who like is dragging down the team, so to speak, think about how that fulfills the narratives that are already in place that are contributing to this particular population struggling, and actually compound that experience of people who are struggling. It doesn't help anyway. It's not necessarily creating health. So there's something I want to read to you from the slides on from this week, They're the population health slides. So there's two sets of slides. They're not very long. I'm not really into big PowerPoints. And I'm certainly not going to read them to you on a regular basis. I trust that we've all gotten this far because we can read PowerPoints. They're there for reference. But on slide number 5, the population health one, I'm just going to move this camera for a second. Society as a whole, or communities within society, are affected by health issues and how they respond to issues. Population health also provides strategies for considering the broad range of potential interventions to address these issues. I want you to think about this statement. And the reason I want you to think about that is what it's telling us is that we are thinking we have created a system within public health called population health, which many of you will be engaged with in your time as health studies majors and then moving into the healthcare field. This is kind of like, buzz talk of, the last 10, 15 years is population health. That we are judging, this is basically saying we are judging the health of the whole based on how we address and respond to the issues of groups within our society. That on some level, the health of our entire society has to do with how well we treat people who are struggling within our society, which is actually quite a positive viewpoint, I think. That we are, the sum is not necessarily greater than its parts, right? That we really only are as healthy and as strong as the people within our society that we stop and take time to respond to and care for. That is ultimately the underlying premise in that concept of taking public health, narrowing it down to population health, addressing the population and hoping that that health then becomes the health of the whole. There is something about that pathway that is intended to be positive and noble. And also I want us to think about the fact that it does contribute to deficit thinking. It does, and it plays out in terms of deficit thinking and bias in medicine, in bias in interventions. The way that we change our viewpoint of whether or not people can utilize our treatments and interventions, or whether they are improved by them, because we automatically think that this population is at a deficit. We don't have very high hopes for them. And you'll see this a lot in your time as health studies majors and moving into healthcare fields. And I want you to start thinking about where you see this in the world. I want you to start paying attention to billboards and to messaging you see on social media, to conversations like, oh, well, people like that, they do those kinds of things. All the narratives around, the pandemic and how people have responded to that. And now take our discussion about the models and apply that to this. So if we are looking at population health as potentially the solution for public health, right? We're narrowing it down, distilling it down to these groups of people who are really holding us down, right? Which model are we using to decide who is at a deficit and who is a population worth studying? I'm going to posit to you that it is still the medical model based on super discriminatory and biased structures and history. And that it doesn't necessarily utilize the models that we discussed in class, like wellness and social and ethical moral. And that maybe if we looked at population health through those other models, we might actually have a different viewpoint. And then to look at how it feels to be in that population, now using the models as your, not just an outgoing model, but now an incoming model. Now these are your lenses, whether, think of them as being like in your glasses, like that's green, that's red, that's pink, whatever. If you are in that population, how are you receiving that information? Okay, well, that's medical information coming at me, but that doesn't address my social, cultural thing at all. That feels very ethically, morally, uncomfortable to wrong. And that doesn't get to my wellness, right? Like, does that address wellness at all? To have this group of people being viewed as a deficit, or dragging us down. Now, I'm deliberately being, or I'm deliberately exaggerating right now, all of this, because I want to make a point, which is to corroborate what I was saying at the end of class on Tuesday, that like a lot of where we have misfires in public health, education and community and interventions, and like, why don't people just do the thing? Why can't they see the thing? Because we have this way of singling people and groups out and then disseminating information to them through one model, forgetting that people are people. They're not just populations and deficits and numbers. They're not just epidemiology statistics, receiving that through multiple models. And most of that information doesn't even touch those other models. There's no social cultural acknowledgement there. There's no ethical moral acknowledgement there, or like what people's ethics or morals might be versus the quote unquote greater good of the system. And there certainly isn't any acknowledgement of their wellness, because if there were, would we make them feel like a deficit? Probably not. So this is all food for thought. I want you guys to consider this concept as you move into your discussion. Your other video tells you a little bit more about the actual logistics of your discussion. The other thing I want you thinking about when you move into your discussions are some of the questions that I posed on the week 2 materials. So on the week 2 materials, when you hit that page, there's underneath goals. I want you to start thinking about, what it means to understand a population versus a public. So this is partly what we're talking about here. What's broader, what's easier to understand, what are the challenges or goals? That's primarily what I'm addressing right here. What we will get into a little bit more is how does evidence get used in understanding population health? And so what I alluded to, and I said we'll get back to, that very short course on epidemiology, is population health makes gathering evidence easier. In fact, the way that we gather evidence is to come up with something called a P-code question. The P stands for population. So by default, in order to actually develop a research question, you have to have a population to study. So how does evidence get used in understanding population health? Well, population health really generates the evidence and then also feeds back on itself to make it agree, right? And this isn't to say that there's something wrong with research and evidence. It's just that it is a limited form of inquiry. And we'll talk a little bit more about that as well. One of the classes that I teach very often is like a research methods and then a translating evidence to practice kind of class for nursing students. So I'll give you a few more tidbits in the upcoming week about how to understand evidence and what it even means. Like what do we mean by evidence in the upcoming week. And it's not as dry as you would think. It's actually a little bit more interesting when you start to realize how do we create evidence and who creates evidence and in what way, and what are the benefits of creating evidence that way, but what are some of the limitations? But what I want you to start thinking about based on this conversation that I'm having with you, so this unidirectional conversation, is how do you choose interventions to have a healthier population and a healthier public? And which ones do you exclude and why? So I want you to start thinking about where the power sits. This is an important piece of public health discussions, public health education, and for those of you who go on into the health education promotion minor or into work that involves health education and promotion, this is a very important thing for us to consider. Can we even agree about what makes a population or society healthier? And this is what you get to discuss in your discussion posts with each other. So enjoy the discussion. I look forward to hearing what you all think. And 100% do not expect you to have all the answers. I just want you thinking about it and throwing out ideas, throwing out more questions to each other. This is how we learn. Even though I do this thing where I'm talking at you, this isn't actually how people learn, being talked at, right? How we learn is inquiry. So I want you to keep engaging with these questions and then answering these questions with each other and then even posing new questions for each other. So enjoy. I definitely will enjoy reading the discussion. I may chime in at some point, but I kind of let you guys get started first. All right, that's all I got for this one. Bye.